So this session is Stop the Spread of Inappropriate Care, How Implementation and De-implementation Sciences Can Improve Quality of Care. So Dr. Patey is a knowledge translation implementation scientist at IWK Health, where I am, and holds a PhD in health psychology. She's also co-director of the Healthcare Improvement Fellowship at Choosing Wisely Canada. Her work sits at the intersection of behavior sciences and implementation research, applying psychological theory and methods to explain and change health professionals' behaviors across a range of clinical settings to improve the delivery of care. Andrea's specific interest centers around whether de-implementation, or stopping an ineffective or harmful clinical practice behavior, and implementation, starting an evidence-based clinical practice behavior, differ, and correspondingly, whether interventions to target each should also differ. The broad objectives of her work are to promote the use of theory and rigorous methods to improve the delivery of evidence-based healthcare through the development and evaluation of complex behavior change interventions. And I will hand it over to you, Dr. Patey.
Thank you, Angela. I should preface this talk with a little slight caveat in that I've just traveled back from Europe. I've been in Halifax 12 hours. So if my words start to go a little wonky, it's probably due to a lack of sleep and the time change. So I apologize for that. I also want to say, as we gather here today, I'd like to pay respects to knowledge keepers, young and old, past, present, and future. In particular, the Mi'kmaq Nation, on whose land, whose traditional unceded territory I live and work. I'm thankful for the generations of First Nations, Inuit, and Métis people who have taken care of Turtle Island, including the land called Canada, for thousands of years. And I'm grateful for the opportunity to be here. I also want to acknowledge and recognize the African Nova Scotia community, a distinct people whose histories, legacies, and contributions have enriched Nova Scotia for over 400 years. And all these communities help sew the tapestry that is the history of our country. So I have kind of four broad objectives for the talk today. I understand I have an hour with, I hope, opportunity for some conversation. So the first thing I want to try to talk about is understanding what we mean when we say inappropriate care, introduce what knowledge translation or implementation science is and why it's important, and show how knowledge translation, and implementation science theories, methods, and frameworks can be used to change clinical practice. And if I have time, and provide an example of how using these theories, models, and frameworks can help lead to practice change in a real world example. So what exactly is inappropriate care? Well, health, as we all know, and healthcare research is constantly being produced, but it takes about 15 to 17 years for evidence to be translated into clinical practice. And yet only 14% of those healthcare interventions with interventions of effectiveness make it into practice. And so there's a gap between what we know and what we do, which can lead to this idea of inappropriate care. And those types of gaps can include a slow uptake of new interventions that are likely clinically effective. So it's a failure to deliver this idea of high value care. There's the premature continued uptake of interventions and technologies that are shown to be ineffective. That's the delivery of low value care. And that's kind of where my nerdy interest related to de-implementation sits. There's a failure to keep up with gradually emerging evidence about existing interventions. There's unwanted variations in care, often associated with health inequities. And there's a failure to keep up with the changing ethos of care. And these gaps mean that 30 to 40% of people do not receive a care according to current scientific evidence. So there's an underuse of effective practice. And 20 to 25% of the care that's actually being provided is not required or potentially harmful. And that leads to overuse of certain clinical practice. In Canada, there was a study done in 2022 where they looked at 174 studies, 228 clinical practices, and 28 million patients. And they reported that 30% of the care received is inappropriate, including both underuse and overuse. The unfortunate thing is that this is not a new statistic. It was originally published or reported in 1998. So 24 years later, it's still a problem. And it's also not a North American problem. Um, there have been reports from other groups, for example, the Brownlee paper that has reported that 25 to 30% of inappropriate care exists in Australia, Canada, Spain, Brazil, and the US, and it even rises up to 80% for certain clinical practices, certain health professionals, certain settings. So with this gap in care, there is an interest in understanding how do we close that gap. And often when we have had these sorts of situations where there's new evidence coming out and people need to change their practice, we end up doing something that we still do, and it's quite common. We develop guidelines and we then distribute guidelines and we assume that that's going to change practice. While it's a good start to tell people what they should be doing or suggestions about what they should be doing, it's generally not sufficient to change practice. So what you end up having then is a guideline recommending we should do something, a group of people sitting in a room saying, well, how do we do that? And then they end up following the second sort of most frequent way in which we try to change practice, which is something that's been coined using the Islagiat model, which is basically it seemed like a good idea at the time. You get an evidence practice gap, you brainstorm solutions, somebody decides on a solution, you implement the solution, and everybody stands around crossing their fingers, hoping it will work. However, there's a problem associated with that sort of model. And while there may be good intentions, it not necessarily is efficient. So it might not help us build on what we already know. It can lead to reinventing the round wheel. So you're wasting resources, you're wasting time. It can lead to reinventing the square wheel. So you're repeating a mistake that somebody else has already discovered is a problem. It may not actually be sufficient, so the square wheel may actually be missing important factors that weren't addressed in its development. And for the nerd in the room, it's not particularly scientific. So it's based on implicit ideas of what drives change, which may or may not be supported by evidence. And implicit ideas can undermine replication and knowledge accumulation. So it's really kind of an expensive version of trial and error. The difference between the traditional approach, which is that evidence practice gap identification, brainstorming, deciding on a solution, rolling with the solution, hoping it works, is that knowledge translation and implementation science approach proposes that before you jump to a solution, you have a more in-depth and thorough understanding of the problem so that you can fully understand why solution, sorry about the image over top of the words, why solution worked or not, and build that cumulative evidence. So I've thrown around these words, implementation science and knowledge translation, quite a bit. And I think it should be appropriate that I provide you with a definition of what those words are. They're often used interchangeably depending on the country in which you live and work. Implementation science was probably more commonly used in the UK and in Europe, while knowledge translation is a Canadian term. So implementation science is the scientific study of methods to promote the systematic uptake of research findings and other evidence-based practice into routine. It's a multidisciplinary scientific study of the determinants or factors that influence processes and outcomes of the implementation of healthcare. It's actually the scientific study of the best methods to promote the uptake of research in clinical, community, and policy contexts, so it's not specific to one area. And the ultimate goal of implementation science is to develop a generalizable, empirical, and theoretical basis to optimize implementation activities and improve healthcare provided to patients and the public. Knowledge translation, according to the Canadian Institute of Health Research, is a dynamic and iterative process that includes synthesis, dissemination, exchange, and ethically sound application of knowledge to improve health of Canadians, providing more effective health services and products, and strengthen the healthcare system. The goal is to close the evidence practice gap or the no-do gap and improve health outcomes and healthcare systems. Goals are pretty much the same. So whether you're doing understanding the methods to do knowledge translation um, or doing knowledge translation, your goal is basically to close the gap and improve health outcomes and health system. The interesting thing about knowledge translation that's slightly different from implementation science is that they've broken it into two sort of categories, CIHR, I mean. So there is knowledge KT practice, which is the doing of the KT, so facilitating the knowledge into practice. I would probably say it's very similar to quality improvement. And KT research is the scientific study of the best ways to do KT, which is closer to the implementation science. So KT practice, quality improvement, KT research, implementation science. Not mutually exclusive, often work very close together and should work very close together. So the really interesting thing about, well, interesting to me, might not necessarily be interesting to you guys, is that over the last probably 30, 35 years, knowledge translation research has evolved considerably. They've developed frameworks, theories, models, and tools that can help guide KT practice and quality improvement. So there's been some work to kind of categorize those frameworks because everybody comes up with a new one and we don't know its purpose. There is a group out of Europe who basically identified three separate categories of process models and frameworks. The first one being process models, which help describe or guide the process of translating the research into practice. So how did you go from A to B? The second group is about understanding or explaining the factors that influence implementation outcomes. So why did things work? Why didn't they work? How do we build on those? And then the third grouping is evaluation frameworks. So these are tools that are developed to help you understand whether your intervention was effective, whether it worked the way you thought it was going to work, whether it's equitable, et cetera, et cetera. Perhaps the most, oh, sorry, wrong arrow. The most common process model and framework in the Canadian healthcare setting is the knowledge to action framework. The inner core is where you develop the evidence in the funnel, and then you work your way around the outer puzzle pieces to develop your intervention, test your intervention, and sustain the knowledge intervention. In the United States, they developed what's called the Consolidated Framework for Implementation Research. And this one has a more organizational systems level, sociological perspective on developing interventions in the healthcare setting. And I will provide these slides to everybody, so don't worry about writing down the references. But it takes a look at sort of like the health system in which people work and how you can work within that system to create change. A model that's been developed in the UK is the behavior change wheel, which obviously takes a behavioral science lens rather than the sociology lens, but still can be implemented at the individual team or system level. And kind of looks at the field of behavioral sciences to understand healthcare clinical behavior and the factors that influence it. A more recent model that has been developed is the Choosing Wisely de-implementation framework. So this framework targets trying to understand the factors that influence stopping a behavior or stopping a clinical practice, which is a little bit weird because you're trying to ask people to think about something that they shouldn't be doing. Um, but it's relatively new. It's only been 5 years old, and it's starting to be utilized by teams around the world to investigate low value care and the factors that influence and designing strategies around that. And then a simpler model, which I think is a really good place for people to start, is what's been coined the French model. It was developed over 10 years ago to help understand how to design an intervention to change practice. It's four simple questions. Who needs to do what differently? What are the barriers and enablers that need to be addressed? What intervention components can overcome those modifiable barriers and enhance the enablers? And how are we going to measure change? Four simple questions. Um, and then you can use any of these models. It's basically which ones you feel more comfortable with, which ones are appealing to the institutions and when you work, and how detail oriented you feel you want to be in explaining the process that you used for developing the intervention. So the third sort of a second category, which is where my interest sits, is understanding and explaining what influences implementation outcomes. This is where you're identifying what are the drivers of current practice, what are the barriers of change, and what strategies can we use to overcome those barriers to change and encourage the drivers. And this is kind of where, as you can see in the green circle, classical theories sit. And the benefit of using the classical theories is that rather than finding out if an intervention or solution worked or not, these theories can help you answer the question of how did it work or why did it fail? So you don't reinvent the square wheel and get really frustrated and angry at the world. And as Angela mentioned, my background is behavioral science, so I have a tendency to look at healthcare delivery as people doing stuff. So it's basically people performing behaviors. And if you think about the work that you guys do in the run of a day or healthcare providers do in the run of a day, you're doing stuff. And you can if you think about it that way, then you can think about all of the behaviors that healthcare providers do, kind of either they're kind of involving whether you're doing preventing illnesses or doing behavior to prevent illness, whether you're doing stuff to diagnose illness, provide treatments, you could be providing general management of health conditions, you're carrying out actions related to health systems management, the dreaded paperwork. And you're also building a therapeutic alliance with the patients and the carers. And they're all just behaviors. They're just stuff. So if we take that sort of behavioral change approach, you kind of think about the successful implementation of healthcare interventions as key actors, whether they're patients, healthcare providers, managers, or policymakers, having to change their behavior and decisions while working in a complex, somewhat ordered chaos in healthcare environment, which means we can then use that substantial evidence from the behavioral sciences to help to support the development of implementation programs and then increase the likelihood of success of practice change. I'll stop there before I kind of go through the sort of example and see if anybody has any questions. I can't see anybody, so.
I'll keep an eye on the chat and see if anybody pops in. I did want to mention for me, this French model is fantastic. Like it seems very user friendly, and the enhance the enablers has always been my go-to. Who's doing it right and how is that happening?
Mhm.
And how can we raise that person and they can lead change? And I find that very effective. So this French model is it looks good to me. I like it. Thanks for sharing it.
Okay, so we're going to use that as the example as I go through all the other tools that implementation science has been developing over the last 30 years. If if there are no questions, I'll keep going. So as I just said, we're going to take the French model and kind of walk through the other tools that implementation science and knowledge translation have developed um, over the last 3 decades to kind of think about where you can embed these tools in the French model as you're designing your interventions. So the first question is who needs to do what differently? And when we think about who needs to do what differently, we're thinking about what care needs to be delivered to the patient. So often that when we initially start to approach these sorts of investigations, we think of that patient-provider interaction as the first point of understanding who the people that are involved in the care delivery. But healthcare providers don't work alone in silos. There are lots of other people that are involved in that care. And it might not just be that patient provider initially. It could be a patient having a conversation with another patient. There are other health professionals, whether it's your pharmacists, the nurses, physiotherapists, surgeons. And those also healthcare providers interact with one another. So that's why they're kind of all connected. And then within the hospital system or within a province, there are the administrators who are also involved in the care delivery. So there's a lot of people who can be involved in delivering that one little component of care with a patient. When we then think about the what, um, the what can depend on the who. So if it's a health professional, it could be ordering tests, it could be communicating with the patient or other healthcare providers, it could be referring the patient to certain services, can involve even scanning or prescribing, examining a patient, or providing advice. For somebody as a department head or a departmental lead, you could be involved in setting policies and providing infrastructure. And the patients also are doing things, the what of their own care around asking questions, taking their medications, attending appointments. And it could be a larger range of health professionals that they do independent of the interaction with the healthcare provider. The when is often something that we sometimes overlook depending on who we are in that health practice, healthcare interaction. And we often don't think about duration of how often we do things for folks. So we then try to start to understand what counts as doing the clinical behavior. Is it something that's done multiple times a day? Is it done every week? Is it done over the next year? Is it something that you do at every opportunity and interaction with that patient, or is it done, on specific? Is it seasonal? Are there certain circumstances in which you are supposed to do the behavior or the clinical practice? Is it something that even occurs before you seeing the patient, while you're with the patient and or after? And how long do you do it for? So there's even a duration component of the when. One of the things that we don't often think about is where does the behavior happen? Is it or clinical practice happen? Is it in the hallway? Is it in the office? Is it in a consultation room? Those contextual things can be really important in trying to understand what the barriers and enablers are. It may seem obvious to those embedded in the clinical practice, but as a non-clinician myself, it's often really interesting to hear people try to explicitly tell me what it's like working in specific environments. I remember we did an investigation to understand the donning and doffing of PPE during the COVID pandemic. And obviously, there's a need for very high compliance in donning and doffing of PPE, as you all know. And we discovered that when we asked two different clinical areas, so one was in the emergency department and one was in an ICU, explaining to us what it means when you're donning and doffing your PPE in these environments. One of the big factors that the hospital system didn't appreciate was where the donning and doffing happens. So in an ICU, they have a specific room where they don and doff. And in the emergency department, they have a taped off area that's 4 feet by 4 feet. And it's not as isolating as in the ICU. So the factors of having 100% compliance in an emergency department were way more complex than 100% compliance in ICU. And that was something that the hospital didn't appreciate until we said, okay, so what's so different about the emergency department environment where that happens? And so even asking that question of where does it happen was very informative for that group. So when you are specifying who needs to do what differently, when and where, it promotes clarity of measurement and expectations about what it is you're asking folks to do. So one of the things that we often struggle with is what do we mean when we say differently? Are we asking folks to do something completely new that they've never done before? Are we asking folks to do something more often than they're already doing? Are we asking them to do something less often? So don't do it as often or don't do it for specific patient populations. Is it something we're asking them to stop entirely? Do they need to do something differently than they did before? So you're replacing existing behavior with something new? And then how are these actions involved in delivering your intervention differ from existing practice? So are the expectations for this new novel clinical practice different than the existing practice that was there before? And the understanding of the reason for trying to understand what it is you're asking people to do differently is that the barriers and enablers to and the solutions for each of those sort of different components may be different. So, it may really seem like we're getting into the weeds around like trying to understand clinical practice, but if you're able to identify who needs to do what differently, when and where, you're able to understand what can potentially be the unique barriers and enablers for each of those folks in each of those different environments. So, a group of folks from Ontario or Ottawa developed a tool called the ACT tool, where they ask you to identify the actors, the action, the context, target, and time for specifying clinical behavior. So I have an example where I used it to try to understand what were the drivers of preoperative test ordering for anesthesiologists and surgeons around low-risk surgical procedures. And so the action that I was interested in was about ordering chest x-rays and ECGs by anesthesiologists during the preoperative assessment or in the preoperative assessment unit for asymptomatic patients undergoing low-risk surgical procedures during the preoperative assessment. So I specified time, target, context, actor, and action. Unfortunately, those anesthesiologists don't work in a silo, so I wasn't able to ask just them questions about it. There's actually other people involved. So not every patient goes to a pre-op assessment unit. They might actually see their family doc who does the preoperative test ordering. But there's also a time component. So pre-op assessment nurses are involved in confirming the appropriateness of test ordering. That happens in the pre-op assessment unit. There's anesthesiologists. They do it for the anesthesiologists, family physicians, and surgeons so that they have all of the required information that they need for their care delivery. And it happens during the preoperative assessment. But before any of that happens there's probably a policy that's written. So chiefs of anesthesiology, surgery, and departmental heads may be involved in writing the hospital policy around what is the appropriate preoperative tests to be ordered for a specific patient. That probably happens over the course of a number of staff meetings. It's for the hospital staff so that they can do the job that they're expected to do. And that may occur initial setup, or they may have monthly meetings where they reevaluate the policy that's being implemented. So it's a tool to just kind of understand um, what you're asking folks to do when you're asking them to think about changing their clinical practice. So I do have a 5 minute sort of activity for you to do as a little bit of a break. One that I know is near and dear to infection prevention and control, physician hand hygiene. So, as you all know, health-associated infections are one of the top 10 causes of hospital deaths worldwide. It affects 10% of patients in acute hospitals. Hand hygiene compliance is an international problem. It ranges from 49 to 57 on average. Poor compliance is not understood. And what we're going to assume is we want to develop a patient safety initiative to improve physician hand hygiene. Um, and we're going to ask, I'm going to ask you to think about using the act. Take 5 minutes to think about the following. What's the specific behavior you want to change? So, what's the clinical practice you want to change? Who needs to do what differently? And you can either put it in the chat or you can just write it down, and we'll just take 5 minutes or so to go through um, what the action is, the actor, context, target, and time. So,
This should be very interesting. Dr. Patey, can you see the chat or would you like me to read things out as they come in once we get started?
I thought I could see the chat, but it's not looking like it.
Okay, when we get to that, I can just read what's coming in.
Okay, wait, now I think I can. Nobody's typed in anything yet, have they?
No.
Okay. Feel free to populate as you finish. Okay, I just saw Heather type in. Thanks. So give it another minute.
Don't be shy. We have 100 people on the on the call, so don't be scared to chime in.
Okay, does anybody want to share theirs? You can type it in the chat, or I'm happy to just go with my example. So Erica made a comment about context, emotional context. Physicians is a gentleman's profession. Well done. So cognizant of time, I'll keep going. Um, so if we think about um, what we're asking people to do, we're just asking people to wash their hands. That's what we're asking them to do. So in this instance, we're asking staff physicians to use an alcohol-based hand gel in the patient's room or hallway, depending on where the little pumpy thing is. Um, the target is for the patients receiving the care at the hospital, and we're asking folks to do it before and after they touch the patient. However, we also want to make sure that physicians have access to the hand gel because there's nothing more frustrating than putting your hand there to try to do it and there's nothing in there. So hospital administrators have to be able to provide the alcohol based hand gel at point of care. They're doing this for the staff physician. They're probably writing a email or a PO to order the appropriate materials. And they would be doing it at the initial setup and making sure that there's a monthly supply. There's also a person in between those two folks. So your housekeeping staff have to supply the alcohol-based hand gel at the point of care. Um, they're doing it in the patient room and hallway. They're doing it for the staff physicians, and they're probably doing it daily, weekly, or as needed. So we've got 3 people, and this is just a small example, who are involved in making sure that physicians are performing the washing of their hands. And the barriers and enablers for each of those individuals may be very different. So depending on where the problem exists, the design of those interventions to help those folks will be different. So if we've identified who needs to do what differently, we now need to know what are the barrier enablers that need to be addressed for those folks. And if we take a theoretical sort of lens to that, and then we take a behavioral science lens to that, we're probably going to look at some behavioral science theories, so some psychology theories. Our ever famous social cognitive theory of planned behavior. Um, there's theory of reasoned action. There's a whole bunch of theories that you can choose. And it can be extremely overwhelming if you're not a health psychologist. It can also be overwhelming if you are a health psychologist. Because going back to that sort of is lag yet model of it seemed like a good idea at the time, if you pick the wrong model, you may miss an important sort of tool or an important driver. So implementation science has developed a tool that sort of synthesizes a whole bunch of psychology theories to understand what are the factors that influence clinical practice. It's underpinned by the decades of behavior change research. It synthesizes key factors associated with behavior change or clinical practice change. It takes 85 constructs from behavioral theories and distills them into 14 domains. It provides a list of topics to explore that might affect behavior, and it's used to understand the barriers and enablers. So this is a theoretical domains framework, 14 sort of simple um, groupings. I like to call them buckets that you can try to identify what are the factors that influence clinical practice. So, for example, knowledge. Do people know what they should be doing? Skills. Do people have the skills to do what they should be doing? Is it part of their job, which would be professional role and identity? Do they think they can do it, which is belief about consequences? Are they optimistic about doing it, or do they just see it as a futile activity, therefore they're not going to do it? Um, what are the good things or bad things that can happen when they do it, and does that influence whether they're going to do it in the future? Have they had previous successes and failures in doing the clinical practice? Is it something they want to do? Is it a big priority for them, which is what would be related to goals? Do they forget to do it? Um, are there resource or context, clinical context issues that can affect whether or not they do it? I talked about that donning and doffing of PPE and how the environment in the emergency department made it really difficult to get 100% compliance. Are there folks that they work with that influence whether or not they do it? Um, is doing the clinical practice something that makes them feel good, or does it give them any sort of worry that they're going when they do it? And do they already have strategies in place to do it? So, Angela, you talked about those successes, those folks that are really good at doing what it is that they're supposed to be doing. What is it that they're doing that they've already figured out how to work through the system to get to the clinical practice that needs to be um, implemented? So, how can you learn from those folks? So the TDF has been used to have conversations with health professionals to understand their views about what helps or hinders their performance of a specific clinical practice. But it's also been used with patients to understand their barriers and enablers to a health behavior. It's been used to develop questionnaires, and also used when evaluating interventions already. So looking at in systematic reviews, if you're looking to understand how an intervention was designed and if they identify specific areas that they were targeting in the intervention, it's a way to actually categorize what folks were doing when they thought about the intervention or what barriers they thought they were targeting. So there is a practical guide to using the TDF that's been developed. It provides a 7-step process for conducting a TDF-based assessment. And this paper that I've identified walks you through the 7 steps, and you'll notice the first step is selecting and specifying the target behavior. So this is where your act would come in. So you would actually be using multiple tools to help develop your intervention or to work through developing the intervention and understanding what the barriers were. So you may decide to do a questionnaire study or an interview study. You could do a focus group. You could do a brown bag lunch to try to talk to people around what are the factors that influence their clinical practice. And this guide also works you through the steps for data collection, analysis, and reporting. So it's a really good resource to try to understand how best to look at barriers and enablers in a more comprehensive way than just asking folks to tell you that we don't have enough resources and we don't have enough time, because there's lots of other factors that can influence clinical practice. So at the end of that sort of a question, you'll have a list of relevant factors that are most likely to influence the targeted implementation problem and the associated behaviors to that clinical practice. And then you're going to then come to, what do we do now? We've just got a list of factors to influence clinical practice. You're then going to try to identify what intervention components could overcome those barriers. There's lots of strategies that you can use. You can do educational meetings, which address a knowledge gap. You can do reminders. You can do use local opinion leaders who can help folks change their clinical practice, or you can do something more complex like audit and feedback. The challenge is we don't know which ones will work in our setting with our colleagues for our specific problem. So we need to know how to choose these intervention strategies. And there are 3 ways that you can do that. Oh, whoa, whoa. Sorry. One is using evidence-based, so looking at systematic reviews, looking at the literature that's already out there to understand what strategies might be useful. Probably the largest database is the one that's been developed by the Cochrane collaboration that focuses on producing high quality, up-to-date systematic reviews to help health decision making. There's over 200 reviews and protocols in the database, so there's lots of stuff in there about different strategies. Um, they have one sort of subcategory in the database, which is effective practice and or health systems care. So that looks at health professional change. And the challenge of these reviews, however, is that there's variable effectiveness. So, for example, printed material ranges in effectiveness from 0 to 11%, depending on the context and the people. Reminders range from 1% to 19% in effectiveness. Even audit and feedback has a variable effectiveness of 1 to 16. Meetings and workshops have variable effectiveness from 2 to 16. So while there's a lot of variability in effectiveness, and we're not 100% clear on what explains the variability, is it specific detailed content of the strategy itself that's not necessarily reported? And are different barriers to behavior change different for each of those types of reviews? So it's important to unpack the detailed content of the strategies. I recognize how much time I have left. Um, so, for example, in the Cochrane Audit and Feedback Review, higher effect sizes were found when baseline compliance was low, when you were measuring individual practices, whether there was a local champion, whether you had written and verbal feedback, when you're comparing it to other folks or a benchmark, whether there was active facilitation of the feedback, and whether people developed action plans. So systematic reviews are a good source for identifying strategies, but they may be effective in your situation, but not necessarily in all of them. And it doesn't necessarily show you how to design or deliver those strategies in the systematic review. The second option is taxonomies. So taxonomies are a classification system that goes a little bit more granular than a systematic review. It allows you a better description and reporting of your KT strategy, and it's more useful in understanding processes and outcomes. So there are a couple types of taxonomies. There's the Cochrane Effective Practice and Organizational Care taxonomy, ERIC recommendations, and the Behavior Change Technique taxonomy. Each of those has a different level of granularity. And I think what's important to note is that depending on which one you use, you'll have a better understanding of how they're being targeted. So, for example, this is a dashboard that's provided by Health Quality Ontario around opioid prescribing. And if you were to describe this using the ERIC or IPAC taxonomy, it would be just called audit and feedback. However, if you use the BCT taxonomy, there are 3 instances of feedback on behavior. There are 2 instances of social comparison. There's 1 instance where you're providing the information about the health consequences. There's 1 instance of using a credible source to provide that information. So there's way more detail in the BCT taxonomy than in the ERIC and the EPOC taxonomy, which may help explain whether your intervention was effective or not. So taxonomies provide clarity, fidelity, replication, and optimization of evidence, but they don't necessarily clarify how to tailor specific to your barriers or enablers. They're a toolkit, but they don't necessarily indicate which tool is best suited. And so the third option, and this is where I'll stop after this one, is what's called a mapping approach, where implementation scientists have linked those barriers enablers groupings to specific taxonomies. So, for example, the consolidative framework for implementation research, that process map I showed you at the beginning, has been mapped to the ERIC taxonomy. So if you identify barriers enablers using the CFR, you can identify strategies using the ERIC taxonomy. If you use the TDF to identify barriers enablers, you can use the tool called you can use the BCT taxonomy to map to the barriers of the TDF. So this, for example, I'll go back one, sorry. The Theories and Techniques Pool is a living database where they are populating not just theory-based linkages between behavior change strategies and barriers, but empirical evidence related to behavior change strategies. So, for example, they have indicated that um, goal setting as a behavior change strategy is really good at addressing, sorry, where'd it go? Okay. Is really good at addressing barriers with intention or barriers with goals. I should not touch my mouse. Um, but problem solving is really good at addressing barriers within belief about capabilities. And this is, as I said, a living document that is continually being populated. So folks that the cells that have no evidence will hopefully, in a number of years or months, be able to have more information about them. So summary for the mapping approach, it can help with developing KT strategies which are fit for purpose. They're targeting identified barriers and enablers, but they don't necessarily provide the answers to everything. We got like 10 minutes left, less.
We have 5 minutes left.
Okay, so
Yeah.
I have a whole slide deck that I will share, but I'll do an overall summary to say um, there's a wealth of research to show that evidence to practice gaps are both persistent and pervasive. Translating research findings into practice is a key challenge for health systems. Traditional approaches to closing that no-do gap are not always active enough and don't always focus on scientific evidence. The goal of knowledge translation or implementation science is to close that evidence practice gap and improve health outcomes by developing tools and methods. There are a lot of tools out there that can help you identify the gap in care, help you identify the determinants, the barriers and enablers, help identify fit for purpose strategies and techniques to address them, and can help you evaluate the interventions, whether you're looking at effectiveness, process, evaluations, fidelity, or acceptability. So I apologize for the speed. It's kind of trying to jam 30 to 40 years of implementation science into 50 minutes. And I want to thank you guys for your time.
Thank you, Dr. Patey. That was absolutely fantastic. And I think I can speak for everyone when I say I knew behavior change was difficult. It's so much more complicated when it's put out like that, but in a wonderful way. And it seemed like a good idea at the time, has certainly been in my playbook for sure. But the ACT framework and the barriers enablers, I think that's really good information. Seeing the evidence from the Cochrane review on the results of the implementation strategies is a little bit eye-opening. But again, you have a whole basket of things and then hope that some of them can make the change that you're looking for. We're a profession that relies heavily on evidence-based guidelines and audit feedback processes. So this was really interesting. Thank
And
you
I
so
think
much. Oh,
no
sorry.
problem. I was going to say, I think those small effect sizes can mean a lot though if you think about like a 10, like a 8 or 10% change, 1,000 people, that's 80 people
That is true.
who
That's
got
very
care
helpful.
that they should get, or who now are not who are not receiving something that they shouldn't. So it looks like a small effect size, but it can be really meaningful in real world sort of application.
If you look at per patient, the changes that are possible. Yeah,
Yeah.
that's a good point. Thank you for that.
And I was just
Oh,
also going
you
to
can see
say,
the comments. Yes.
I do a TDF workshop. It's typically 3 hours.
Oh, wow.
I also have done a behavior change strategies workshop that's an hour and a half. So like this is
Oh,
6 hours and 50 minutes. So it's
yeah.
just sort of like large sweeping flyby of
Tip
the
of the
knowledge
iceberg.
translation
Yeah.
field. Yeah.
Well, thank you very much. That was amazing. And we will be, for the other attendees, we'll jump off and head into our last session now. Thank you very much, Dr. Patey.
Thank you, everybody.
Bye.